five eminent speakers من مختلف المجالات. I wish first to introduce Professor Ayman Elsabaei. هنتكلمنا على case record. اتفضل يا دكتور.
Professor Ayman, Professor of International Medical Center.
Electrical Academy. قوات مسلحة.
ساعات يا عم. ممكن
مساء الخير. I'm very delighted to be here today with you in this nice meeting, and I would like to thank the organizing committee and Dr. Mike Shar'awi, Dr. Haytham, Dr. Amr for inviting me today. And I'm going to present today a case presentation regarding the hemodialysis and special population. And I chose one of the elderly patients, as we know that the elderly population now is increasingly, exceedingly, and it's more than 6.5 billion elderly patients now in Egypt. So we'll try to go through these patients and try to be interactive and try to find the accurate diagnosis and the swift approach to this patient to try to save his life. This patient is 76 years old man with a long history of chronic kidney disease, cardiac disease, ischemic, hypertensive, and had a past history of COPD. He was admitted to our hospital because of pulmonary edema, was dyspneic and agitated. His kidney disease of unknown etiology. On examination, we found he's hypertensive whose blood pressure was 170 over 75, whose respiratory rate quite fast at 24 per minute. There were bilateral wheezes over both lung fields. His heart and abdominal examination was unremarkable, without any peripheral edema. Something. Lab results showed that serum potassium was 143. His potassium is a little bit high at level of 5.9. Blood urea nitrogen 70. Serum creatinine was high at level of 5. And albumin 3.7. Hemoglobin level 11.8. And platelet was normal. And white cell count a little bit high at level of 12. Urine analysis showed proteinuria and some hematuria as well. Chest X-ray showed evidence of pulmonary edema. Renal ultrasound showed small right kidney. The patient refused to have dialysis, and therefore he was admitted to the ICU for supportive management. On the third day of his stay in our hospital, he remained volume overloaded and hypertensive despite intravenous furosemide, and his creatinine rose up to 5.5 and the urea nitrogen up to 90, and the patient convinced and consented to have hemodialysis eventually. After 2 sessions of hemodialysis, his volume status and blood pressure improved, but the patient complained of mild right upper quadrant abdominal pain and nausea at the end of his second treatment. He was afebrile and denied to have any diarrhea or vomiting or chills. No jaundice. On examination, his abdomen was slightly distended with hypoactive bowel sounds and right upper quadrant tenderness. So now the patient had an right upper quadrant tenderness. He had an abdominal CT which revealed distended gallbladder with sludge and diverticulosis of the sigmoid cord. He had an upper endoscopy done, showed some evidence of gastritis. So what do you think your differential diagnosis at this stage of our patient? He had, this patient, 76 years old man, presented with chronic kidney disease, started to have hemodialysis because of volume overload and increased creatinine and blood urea. And then during his stay started to complain of right upper quadrant, and the CT showed some distended gallbladder with sludge. Based on the history and the presentation, we start to think about what is the differential diagnosis. Is it small bowel obstruction or acute mesenteric ischemia, perforated diverticulitis, ischemic colitis, or perforated peptic ulcer, acute pancreatitis, acute? It's a lot of differential diagnosis we have to put in our mind in this patient. But he had an abdominal X-ray which didn't show any fluid level, so small bowel obstruction is a little bit not in our mind in this stage. Perforated peptic ulcer, he had as well gastroscopy, which didn't show except of mild gastritis. He had serum amylase, which a little bit high, which can be due to chronic kidney disease, and it can be due to anything else, perforated peptic ulcer, acute mesenteric ischemia, anything else can increase amylase, but it's not that so high, so pancreatitis as well wasn't on top of our diagnosis. Acute cholecystitis, well, the patients didn't have any calculus in the gallbladder, but at the same time he had distended gallbladder with a sludge inside. So it might be gastroenteritis, no, acute appendicitis. So we started this patient on intravenous antibiotics with ceftriaxone and metronidazole. Started for presumed acute acalcular cholecystitis, and over the next week the patient had few hypotensive episodes on hemodialysis machine. واحنا بنستخدم يعني hemodialysis machine كويسه قوي يعني صعب يعني في حاجه. With systolic blood pressure dropped to 80 millimeters mercury, associated with marked increase of abdominal pain. So the abdominal pain didn't improve. بالعكس the patient's abdominal pain زاد. And starts to get rebound abdominal tenderness and leukocytosis with white cell count of 24 with 90% neutrophils. So we had to repeat abdominal CT scan with intravenous contrast, which showed mild ascites with increased small bowel distension. And to be honest, at this stage, I asked one of the consultant surgeons to review my patient for further advice. So I think at this stage, the patient didn't respond to the intravenous antibiotics and ceftriaxone and metronidazole and dialysis and other supportive measurement. So we have to revise our differential diagnosis. Is it acute mesenteric ischemia or strangulated small bowel obstruction or diverticulitis? He had a past history of diverticulosis before. So I think you may go more for mesenteric ischemia. Well, should we intervene at this point, or should we do anything else regarding the investigations? Well, CT angio or mesenteric angiography?
I think we want to spy CT gastroenterology. It's not excluded by diverticulitis anyway. You can't exclude diverticulitis. Although it's going on the left side, but it's happening on the right side of the body.
Yeah, well, yes. But I think at this stage, we didn't do the CT angiography or mesenteric angiography because the patient had an acute abdomen. And it should be contraindicated to do it at this stage. So we actually, my colleague, the surgeons, out of his experience, he said, we should intervene now. So the patient had a diagnostic laparotomy, converted to exploratory laparotomy, revealed ischemic small bowel of the distal ileum with at least 2 areas of necrosis that was resected with anastomosis and insertion of feeding catheter per jejunoscopy. And this is a picture. And the histopathology of the small bowel demonstrated transmural ischemic necrosis with hemorrhage and non-occluded mesenteric, non-occluded mesenteric. We didn't find any thrombus or embolus. The patient, fortunately, made a very good, steady recovery, and he was discharged on 11th day of postoperative day on regular hemodialysis. This was the case, and I'm going to review a little bit to give some information about the acute mesenteric ischemia in our population in hemodialysis and in general population to remind ourselves about this important and difficult to diagnose entity. So with the sudden onset of symptoms, cardiac disease, and pain out of proportion to physical examination in an elderly patient with chronic kidney disease starting dialysis, acute mesenteric ischemia should be on the top of our differential diagnosis. And this is require a high degree of suspicion. And the history of other diseases like cardiac disease, valvular disease, AF, or should alert. It might be an embolic phenomenon as well. The gold standard is mesenteric angiogram, but CT angiogram as well is more and more being used, but probably it's better to be used before signs and symptoms of peritonitis develop or acute abdomen develop. And the treatment in acute mesenteric ischemia should require aggressive resuscitation and hemodynamic monitoring as patients become critically ill very quickly, and the mortality in these cases are very high. Urgent surgery with urgent surgery with visceral revascularization is required. After this, evaluation of the viability of bowel segment should be performed with resection of any necrotic portion. The acute mesenteric ischemia might be thrombotic, embolic, or non-occlusive. And our patient was non-occlusive, we didn't find anything. And this table is very important. It shows that the percentage of cases of acute mesenteric ischemia, it's embolic in 50%, artery thrombosis in 30%, vein thrombosis in 10%, and non-occlusive in about 30%. And surprisingly, it's up to 90% mortality rate in non-occlusive mesenteric ischemia, if not being treated early and aggressively. And even if you treat it early and aggressively, it is still 50% mortality rate in these cases. And the risk factors or precipitating factors in these cases include the cardiogenic shock, congestive heart failure, hepatic disease, renal disease, chronic kidney disease, or on dialysis population as well. Some drugs as well can cause mesenteric vasoconstriction like digoxin and others. This is the instance. It's 1% of all patients with acute abdomen have acute mesenteric ischemia, and 10% of them are over 70 years of age. And it's increasing, as you see in this diagram, with age. All-cause mortality in these cases is 70% or more, and once bowel wall infarction has occurred, the mortality as high as 90%. The predictors of mortality: older age, hepatic renal, metabolic acidosis, hypoxia, and sepsis. The mortality is highest for thrombotic AMI, followed by non-occlusive mesenteric ischemia, embolic, and venous thrombotic acute mesenteric ischemia. Early and aggressive diagnosis again and treatment shown to reduce the mortality if diagnosis made before its onset of peritonitis. What's non-occlusive? Non-occlusive is a low flow state, no documented thrombosis or emboli found. Low cardiac output is a cause reduced mesenteric flow or mesenteric vasoconstriction by drugs like vasoconstrictors, for example. Usually develops in the setting of pre-existing critical illness like congestive heart failure or chronic kidney disease, and especially on hemodialysis. And by the way, it can happen as well in CABD, but it's less than the hemodialysis patients. The early clinical picture in this case is non-specific. You couldn't swear this is a mesenteric ischemia or non-occlusive mesenteric ischemia. It's non-specific. Severe abdominal pain and minimal abdominal findings when you examine the patient. The preceding symptoms: mesenteric angina, العيان بياكل بطنه توجعه, pain with meals and weight loss if it's chronic. History of ischemic heart disease, sometimes in acute mesenteric ischemia can source in AF, low flow states in moribund patients due to underlying critical illness. And if peritonitis develop, usually signify dead bowel. Abdominal X-ray in the early course of the illness are normal, but later it show adynamic ileus. And laboratory tests initially normal, but with time it started to get leukocytosis and it starts to get hyperamyloidemia and lactic acidosis. Therefore, high level of suspicion again and active search for the diagnosis in the early phase to prevent bowel necrosis and infarction, because that will be a very hard mortality. CT angio, mesenteric angio, but not in acute stage after developed peritonitis. And this is a picture of it. Non-operative treatment only if no peritoneal signs, usually in emboli. Selected infusion of thrombolytic agents can be helpful, like babaverine, to relieve the associated mesenteric vasospasm. Only cessation of abdominal symptoms and angiographic resolution can be regarded as a success. In non-occlusive, in NOMI, a temperature improved standard flow by restoring altered hemodynamics early. Selective intra-arterial infusion of vasodilators. In emboli, the patient should be on longer-term anticoagulant. Operative treatment: once the patient develops peritoneal signs, failure of non-operative management, and two possibilities: might find a frank gangrene, ischemia, or and questionable viability of that issue. What about NOMI or non-occlusive mesenteric ischemia in hemodialysis population in our patients, especially elderly patients? It has become increasingly recognized as a highly dangerous complication in hemodialysis patients. End-stage renal disease patients have many risk factors for this NOMI: atherosclerosis, congestive heart failure, diabetes, and hypertensive episodes on dialysis. So hemodialysis patients show mainly NOMI in contrast to general population. General population أكثر acute mesenteric ischemia due to emboli, due to thrombosis. Like in our hemodialysis population, you will find the non-occlusive mesenteric ischemia much more common than the general population, and usually develops frequently on the cecum and on the right core. So at the end of my presentation, I will conclude by take-home message to my friends and professors. It's acute mesenteric ischemia is potentially fatal complication in chronic hemodialysis patient, and the major cause of an acute abdomen in this population. Identification of patient at risk and the prevention of intradialytic hypotension by the new techniques of dialysis may help to reduce the incidence of NOMI in chronic hemodialysis patient. Acute mesenteric ischemia is still a challenging diagnosis to do in the light of its relative rarity, non-specific clinical picture, and absence of diagnostic laboratory tests. High index of suspicion following risk profiling patients with acute abdominal pain should prompt diagnostic targeting using CT angiogram or mesenteric angiogram. And at the end, and it's very important, interdisciplinary team with your colleagues in surgery or cardiology or the other team in the same hospital. If you do an interdisciplinary team, I think it's very important and very crucial in such cases. And thank you very much for your attention. Any questions?
Any questions for Professor Ayman?
Only one question. Because of the time factor, only one question.
ما اقدرش اسال طبعا سياده اليوم وسياده الحبيب لا why didn't you combine the CT from the start? Oral barrier graphene follow through with colon barrier او graphene and CT angio.
بص، هو لو الزمن رجع بيا في الاول قبل ما يبتدي تضرب البريتونايتس كنت عملت CT angiogram من الستارت. بس الاول ما كانش واضح بصراحه، وده النقطه ان انا الفايده من الكيس دي ان انا اقول لا احنا نبتدي نعمل الكلام ده بدري. يعني